So I'd like to welcome you to this session called Value in Healthcare, Drivers of System Reform. This is a session which has been organized in collaboration between the World Health Summit and the World Economic Forum. First example of these two organizations doing a joint effort. My name is Stefan Larsson. I work with the Boston Consulting Group and am supporting the World Economic Forum in this particular project. Sorry, that's my phone calling. I need to shut that off. I will introduce, with a few minutes, introduce the session, and then we will have the panel presenters who will give a short introduction to their perspective on the topic value in healthcare. And then after that, we will have a panel debate, a panel discussion. So the way we've structured this is a brief intro, the five presentations, and then the panel. And I'll introduce the panelists a bit later in this introduction. But let me start with a picture providing an overview of healthcare globally. It's one of these let's look at everything at the same time pictures. And if you try to describe healthcare globally in two axes here, the y-axis on this chart is health-adjusted life expectancy, and on the y-axis, healthcare expenditure per capita. You find two categories of countries, basically. The developing countries who rapidly are improving their life expectancy with growing wealth. And then you have the rich countries who don't really change health-adjusted life expectancy at all, but spend an awful lot more. This is not a picture which is surprising to any of you, but it is a picture that is important to bear in mind as we look at how healthcare systems are able to deliver health to their populations in proportion to the money that's spent. And it can be argued that in these nations, we spend at times an awful lot more without getting very much more health out of what we're spending. And those of you who come from the wealthier part of the world know that healthcare is described as being, in many cases, in a crisis, where costs are escalating faster than is sustainable, where people working in the healthcare system are unhappy with the work environment, and many patients find that they're not getting the help they need, either by having to wait or not finding that the system caters to their needs sufficiently. We both see in these wealthiest nations large variation in clinical practice, where in some countries you do twice as many hip replacements than in others. You find huge differences within the countries in healthcare spending by region or by hospital per capita. But you also find huge variation in the quality of care. What is the outcome of treatments in one hospital compared to another for the same procedure, the same disease? This is, of course, very concerning given the amount of money spent. And we need to ask ourselves, are we managing healthcare in the richer part of the world the right way? And also, we need to ask ourselves, countries that are moving up the wealth ladder and come from poor circumstances and are developing their healthcare systems, should they replicate the model out here? Or should they find a different way of leading and organizing their healthcare? And that's the theme we want to discuss today. Before we move into the specific presentations, I'd like to share a couple of analyses to illustrate the point. So one is this one. This is the country that spends most on healthcare in the world. You would assume it is the most sophisticated healthcare system. But what you find when you analyze healthcare delivered in the United States is huge variation in outcome depending on where you live. And that's not proportional to the wealth of the population. That only answers or explains a small part of the variation. But you find between 2 and 61-fold differences in clinical outcomes. We've done a study looking at 24 outcome metrics, such as mortality for myocardial infarction. Huge differences depending on where you live. And the largest explanation for it seems to be clinical practice, the experience of the clinical teams, rather than only socioeconomic factors, which of course do play in importantly, but the differences in clinical practice seems to be much more important. Now, given that the nation that spends the most on healthcare shows this pattern, our view is that we need to think differently about how we manage healthcare. The current model is simply not sustainable the way it is set up. And we think what we argue is you need to look at the population at large and ask yourself, for each one of the segments, whether that segment is frail elderly or somebody or a group of schizophrenics, what is the outcome that we are seeking to achieve for those patients? Are those outcomes, are we achieving the optimal level? And how much resources is spent all in all for that particular population segment to achieve the outcomes we aspire to? So we need to define by patient group or by population segment, what are the outcomes that are relevant for that patient group? What matters to those patients? And we need to compare that to the resources used for the full cycle of care for that patient group. This is what we call value in healthcare, the topic for today's meeting. Now, we've seen many, many examples around the world that when you measure outcomes, you do so in a fashion that's with high quality, so the metrics are well thought through and the measurements are done with high quality, and you make that information transparent so you can compare hospitals with each other, for instance. You get a cycle of continuous improvement. Physicians will trust the difference is meaningful. They will try to learn from those who have the best results, implement it themselves, and you get the cycle of continuous improvement. This leads to improvement in healthcare value. It leads to both improved outcomes, reduced variation between providers. It often leads to reduction in medical costs because you do it right from the start, and it stimulates continuous improvement. Last year at this meeting, we had a panel with a number of speakers who illustrated examples of how this works in practice. One was the Martini Clinic from Hamburg, which is the world's largest center for prostate cancer surgery. They have shown outstanding results on the back of measuring outcomes, driving improvement as founded on outcomes measurement. We also had a presentation by the CEO of the Karolinska University Hospital in Stockholm, Melvin Samsung, who was describing a new model in which they're organizing the hospital, which is entirely focused around patient groups rather than expert areas. Expertise being as important as it's been in the past, but not the organization unit. The organizational unit is the patient group. And he described a bit of how they are progressing in that work. And finally, we had the leader of one of the disease registries in Sweden that is using the national population for registry-based randomized trials, where he showed that they very rapidly have been able to demonstrate parts of a clinical protocol which were, in fact, not contributing at all to survival of heart attack patients, and therefore could eliminate procedures that were not beneficial to patients, but simply just added cost to the system. These randomized trials have been described in the New England Journal of Medicine as a paradigm shift in how we do clinical research, something we think will be important in the future once providers around the world measure outcomes in a standardized fashion. Today, we want to discuss the healthcare system. So the Value in Healthcare project has the purpose of describing what would a healthcare system look like where value is the focus, where we're able to measure outcomes, we're able to gather that data and use it for both research and management purposes. And there are a couple of building blocks which are the foundation for this work that the World Economic Forum has commissioned. The first one, the first aspect of this, the first block, is to do a proper population segmentation. A meaningful segmentation could be, which is natural in healthcare, diagnoses, but you also have a population that doesn't have diagnosis, who may have risks to become ill or who need preventive treatment. We need to look at the population at large and have a proper segmentation of the population so that we can define what are the outcomes that are meaningful for that group. For a young child that we vaccinate for measles, of course, not getting measles is the outcome measurement. But for somebody who has heart attack, we need to define precisely what is success for treating a heart attack patient. Thirdly, we need to have a categorization of the interventions. So how do we match the population segment with the intervention? When we have the right match, we will have good outcomes. When we treat the schizophrenic the right way, we will have a good outcome. So these three are the backbone of this framework that we're working on. Fourthly, we need to have incentives. Payment models need to be in line so that this change is encouraged. Or at least we need to have payment models that don't prevent us from focusing on quality. There are some of the fee-for-service models that are often used in many nations that actually, where the hospitals will lose money if they have higher quality. And that's, of course, something we need to change. It needs to be better for a hospital to improve the quality for its patients, not the other way around. We know examples of hospitals where the profitability is higher if you have to re-operate the patient than if you operate it correctly from the start. Those models are, of course, crazy if we want to drive improvement of healthcare. And finally, we need to be able to benchmark and compare. We need to be able to have transparency so we can find which institutions have the best results and can drive improvement. And finally, we have three enablers that we think are critical, which work across these 5 building blocks. The first one is the structure, the organizational structure of the healthcare system. Do we think of primary care, secondary care, tertiary care as independent from each other? Or do we have a means by which it's easy to coordinate along the care chain so that we treat the patient at the right level? It should be in the interest of the university hospital for a patient to be treated in primary care, and vice versa when it's the right thing to do. Secondly, informatics. Data IT systems and the data available, the interoperability of system needs to be there so that we can rapidly place a patient in the right place and know exactly what has happened to that patient when the patient comes to one of the units. And finally, and very importantly, policy. Public policies that make it easy to measure outcomes, that makes it safe, but also easy to use the data in ways that will drive innovation and improvement, but also policies that make it possible to have reimbursement models that will favor a drive towards better healthcare value. So this framework is the basis for the program the World Economic Forum is leading at the moment. It's a 2-year program, and the first 6 months have passed, and so the work is right in the middle of it. And this meeting today is a part of that effort. And so in order to illustrate some of the parts of this framework, we put together a panel today of leaders who are engaged in different ways in the system of healthcare value and are having different roles in trying to drive this agenda of improving healthcare value for our populations. The first speaker in our panel is Christina Rongemark-Åkerman. She's the president of an organization called ICHOM, the International Consortium for Health Outcome Measurement. ICHOM is defining international standards for how to measure quality so that we could compare outcomes across different nations, and not only within countries, but between countries, both to be able to find best practice, but also to be able to enable research and development and innovation on the basis of health outcome measurement. The second speaker is Erik Hans Eddes, who leads an organization called DICA in Netherlands. DICA has established in a few years an IT platform for gathering outcomes data across Netherlands and also data on healthcare resource use, so to enable the Dutch clinical community and research community to use this type of data for research. So he will speak about what has happened in Holland in a few years, illustrating that you can accelerate the movement towards value-based healthcare with the right support from policymakers and clinicians around the country. The third speaker is Norbert Hauser, who's the chair of the board for the Global Fund. And Norbert Hauser will speak to us about the developing countries. It's easy to look at this and say this is a development that will happen in the rich countries. But Norbert will make the point that this is as relevant for developing countries as for rich countries. We need to, in developing countries, make sure that we use the resources the best possible way to drive improvement of healthcare. And as these countries develop their healthcare system, they should not try to mimic what we've done in the West, but try to organize around patient groups to make sure that you get the best possible health for the money that's invested. The next speaker is Jan Kimpen from Philips, who's the Chief Medical Officer of Royal Philips. And Jan will share with us the perspective of informatics and IT, how important that is to drive this development and enable this development, and some of the thoughts that Philips has on how this needs to take place. And finally, the last speaker this morning will be Paul Hudson, who is the Chief Executive Officer of Novartis Pharmaceuticals. And Paul will describe to us how he envisages the role of the pharmaceutical industry in this space, where if the pharmaceutical industry is measured on outcomes, how can they engage and play a broader role than their current role, which has been to try to sell a pill, but instead to be part of the solution for patients beyond simply the role of the pill. And so what we hope that this panel will bring to all of us is the breadth of value in healthcare and the important role that different stakeholders have to play in order for this development will happen to the benefit of patients and to the benefit of our societies and the productivity of our healthcare systems. So with that, Christina, what we'll do is we'll ask the speakers to come up one on one, and then after they've spoken, sit in the panel. So I'll start with you. Thank you.
So, good morning, everyone. Thank you very much for the invitation. And having listened to this introduction and heard the word outcomes several times, I would like to take a closer look during my presentation on what is an outcome? We measure a lot of things in healthcare today. But to be honest, we mostly measure structural metrics and process measures. Metrics that we believe will lead to an outcome, but we don't necessarily know it. Days in hospital, antibiotic injections before surgery, etc. If you take a look on the slide that you see in front of you right now, and you focus on the left-hand side, survival is, of course, a very important outcome. That's a very important outcome when you have a specific medical condition. In this case, it's illustrated by the 5-year survival for patients with localized prostate cancer. And the example here is Germany and a clinic in Germany, which has already been mentioned in the introduction, the Martini Clinic in Hamburg, who are specialized in treating patients with localized prostate cancer. And if you compare the important outcome of survival, it's very similar between Germany in general and the Martini Clinic. It's a good outcome. But when you survive and live with this more or less as a chronic condition, we know very little about to what life do you survive. How can you live your life and be part of the society, contribute to the society, and thereby to the economic growth of the society? And in order to understand that, we need to involve the patients and understand what are outcomes that matters to you. And having done so, you can see that for patients with this medical condition, 2 areas stand out. It's to stay continent after the treatment, and it's to keep your sexual function. And when we start measuring those outcomes, you can see huge differences between a clinic who has for many years focused and measured those outcomes compared to the German average. So this is how we define outcomes that truly matters to patients. focused on the specific condition for that patient. And this gives us a unique opportunity if we focus ourselves on those kind of outcomes and start our journey towards value-based healthcare with that, to organize the healthcare, as has already been alluded to in the introduction, along the patient and towards outcome that truly matters to patients. That will define how we deliver healthcare in integrated ways. That will promote collaboration and improvement, because if you focus on what matters, everyone contributes, and you will then together work and find ways of improving those outcomes. It will also show to you treatments and interventions that actually not improve the outcomes, and thereby it might even decrease the outcomes or worsen the outcomes, and thereby highlight areas of taking out services, taking out interventions, and thereby also being able to take out resources and cost. And this will support us in the move from what we currently see in most ways, volume, towards value. So that's why we believe it's very important to start with the outcomes, define them, and thereby you also come to the cost side automatically, or the resource side. And with this in mind, ICHOM, the organization I work with, was formed in late 2012 as a non-profit organization to drive in the direction of unlocking the full potential of value-based healthcare by defining these outcomes and make them defined on a global base via gathering healthcare professionals, patients, and carers, and discuss what are the outcomes that really matters to patients, but not only define them on an international level, but also drive adoption and reporting of these measures worldwide. Because when we make them international, we open up a whole world of possibilities of comparing ourselves, making ourselves transparent, learning from each other, sharing best practices, and thereby improving outcomes, and by that also value. For less than 4 years, I would say, since late 2012, we have been able to complete 21 standard sets, covering 45% of the disease burden. And you can see them briefly mentioned here. What is exciting to see is that it's possible to agree on those outcomes across many countries. It's also very reassuring to see how the interest in developing these standards is constantly and rapidly increasing. And on the right-hand side of this slide, you can see the ones we are currently starting. And I would like to specifically mention the hypertension, which is number 6 on the right-hand side, which is an increasing drive we see from low and middle-income countries to start developing together with more developed economies outcome standard sets in order to, as we have heard in the introduction, be able to move in this direction when building healthcare systems. So this is a very exciting moment for us when we have participants from all parts of the world, truly not only well-developed economies in our standard set development. We are also discussing more and more the multimorbidity we see and the importance of not only measuring condition by condition, but also looking into when you, for example, grow older and have multiple conditions, how can we then find a common denominator for those outcomes in order not to have patients to measure and answer outcomes for all conditions, but is there a common denominator? That's why we have just finished our older person standard set. We are into developing an overall adult health, as well as moving towards pediatric health. And as has already been mentioned, we all know that in the mental health area, the behavioral health, we see a lot of needs to discuss outcomes that truly matters to patients and to define those. This is an example, in this case, the coronary artery disease set, and you can see how this is set up. We start, of course, with the very important piece of surviving, which is the first important outcome. And then we move into what kind of life do you survive to? How well can you live your life? And for how long can you live this life before you have a deterioration in your medical condition or treatment-induced other illnesses? So these are the tiers that these standard sets are built around. And what we see as the newest area here to start measuring, which many quality registers around the world have maybe some of, but not all of, is then the patient-reported piece. That's to truly understand where I started this presentation, to truly understand what matters to patients to be able to live your life as fully as possible. And that's the piece that we now see as very, very important to start implementing and benchmarking in order to drive towards increased value in healthcare. Thank you very much.
Ladies and gentlemen, good morning. The next minutes I will take you on a journey how we established a nationwide platform for clinical registries in the Netherlands, improving healthcare in the Netherlands with the participation of all stakeholders, hospitals, doctors, and the inclusion of all patients, combining robust quality data with financial data and the possibility of hearing the patient's voice. This is real about value-based healthcare. And as the Dutch Institute for Clinical Auditing, we are a not-for-profit organization funded by medical specialists. We have merely 23 clinical registries running at this time, half of them covering the benign diseases and half of them covering malignant diseases. We are the largest supplier of healthcare data in the Netherlands, not only towards the hospitals for improving healthcare, but also in the open domain for transparency. Quality in healthcare. We started some 10 years ago with all kinds of stakeholders and media asking us different things at different times. At the time that volume, the more the better, was considered the most important predictor of quality. And this produced a variety of ranking lists. As medical professionals, this opened our eyes because we realized this wasn't the way, that we had to know the exact figures, that we had to know exactly what we were doing if we wanted to improve ourselves and show our results to the outside world. And this is how we started, defining strict preconditions, and important things are ownership, finance, registration burden, privacy and security, but it starts with speaking the same language, making data comparable. And the first thing is about strict definitions. Because, for instance, in my expertise, colorectal surgery, if you have an anastomotic leakage, which is a very serious complication, anastomotic leakage can be a small oozle on an X-ray with a further healthy patient, but it also can be, excuse me, but, but it can also be a deep septic patient with 2 loose ends of colon going to an ICU and dying within a day. So it's all about definitions, and that's why the iCharm initiative is so important with aligning data sets, makes data real comparable. But it's also about case mix, because it's a very different way if you treat a further healthy guy like me during office hours compared to a very old lady of 80 years old in the weekend with all kinds of diseases. For colorectal surgery, this old lady has a chance of mortality of 20–25%, while with me it's around 2%. So you have to correct for case mix to make this data real comparable. And it's also important that for institutions to give their data, that they trust the data. So what we do as DICA, we perform random site visits because it's essential that data are complete and data are valid. For instance, in the Netherlands, institutions for colorectal cancer, they treat 100 to 150 patients. The mortality rate is about 2%. If you forgot 2 patients, you become a best performing hospital instead of a worst performing hospital. So that's why we perform random site visits. And another success factor is the balance, the delicate tango between this DICA bottom-up initiative in relation to the top-down pressure of mandatory delivery of external indicators to the Inspectorate of Health, insurance companies, patient groups. And I think this is a real importance. Another success factor is the online feedback of results. We have a transparency cycle. Once every year, hospitals have to show their results. But we deliver back the results on a monthly basis with a nationwide benchmark. And this is one of the presentations. You see exactly how you are performing related to the results of the nation. So you know if you are under or overperforming. And this proved to be a very important improvement tool. You will never be surprised. You have the chance to improve during the year. And this is what we see in all the domains we're active in. This is the circumferential margin after rectal cancer. It's the pathology report, which has to be known if all of the tumor is taken out, which is a very important indicator because if it's not known, maybe some tumor is left behind, which reflects the survival rate. And we were surprised because there was a very large survey in the Netherlands. Everybody was obliged to register the circumferential margin. Everybody said, well, it's not necessary to register this. And when we started, we noticed that it was only in 50% of the cases known. But what we noticed is that during the year, it improved above the 90%. And what we also see is that the variation diminishes. And it shows us 2 things. It's essential to keep on registering. If you reach your results, continue, because otherwise it falls back. And this feedback makes sure that the quality improves and the variation diminishes. And we see it with complication rate, we see it with mortality in all the 23 domains we're active in. But it's not only about quality, it's also about costs. For instance, in the Netherlands, and Stefan also pointed it out, in the Netherlands, Dutch healthcare, it's 90 billion euro. It's account for 13% of the gross domestic product. In the US, it's above the 20%. In Holland, people are afraid it's rising above the 30%. Healthcare becomes prohibitive. It's one of the main subjects of the next elections. And it's strange that such a large industry like healthcare, there isn't reliable management information, which we need. For instance, an industry like Philips. I think Jan has his management information on a very regular basis to see how it's performing and to come to a manageable industry, a manageable healthcare and an efficient healthcare. And this is what we do. We combine our quality data with financial data. And what you see on the graphic here, this is the complication rate. These are hospitals with a less than expected complication rates. They are performing better. Here are the hospitals with a higher than expected complication rate. And on the y-axis you see the amount of money per patient. And here less money than expected per patient, and these are higher costs than expected per patient. These are the best performing hospitals who deliver the best care against the lowest costs. And these are hospitals with less than expected quality and higher than expected cost. These are, as we call, hospitals with improved potential. But these are the best practices. These hospitals can learn from these hospitals. And we looked at this. It can be a cost efficacy of €4,000 per patient for the colorectal domain. And we estimated that for surgery alone, this could mean €20 million for colorectal cancer, the surgery alone. And we see equivalent potential in all other groups. And we estimate that we can reach a national potential in savings of 10 to 20%, which was already noted, for instance, by BCG, who evaluated the Scandinavian model a few years ago, and it's also noted by Mr. Kaplan and Mr. Porter recently. Ladies and gentlemen, I will end my presentation. Those were the days. My father was an anesthesiologist, and he worked in a hospital. This was reality. He was the boss, and sometimes when I work in the hospital, I think about those times. But, well, is this the hospital boardroom of tomorrow? I think this should be the hospital boardroom of today. Thank you very much.
Morning, ladies and gentlemen. Asking if the value-based healthcare model can be applied everywhere, the answer, of course, is the model certainly can apply everywhere, and the global community should strive to reach a value-based healthcare everywhere. But the question, however, should rather be to what extent can the model be applicable in specific countries in order to deliver improved healthcare outcomes for defined population segments at the same or lower cost. In that regard, one has to take into account countries' specific context. The Global Fund is primarily investing in developing countries, and one of the key challenges there is an insufficient allocation of resources to build a functional, resilient, and strong health system. In fighting HIV, TB, and malaria, the Global Fund is confronted with severe social and cultural issues related to poor infrastructure, limited access to education, gender inequalities, legal and human rights barriers, stigma and discrimination, cases of corruption and fraud, ongoing civil wars and refugee crises, and many more. In sub-Saharan Africa, in high disease burden countries, a structural transformation, social, political, and cultural, still needs to happen in order to strengthen countries' health systems with access to all. Nevertheless, certain aspects have to be recognized, and we must not forget that in many developing countries, a lot of healthcare is delivered by communities in absence of a state-funded health system. And developing countries, and that's a benefit or a chance, in many developing countries, they have fewer or no sunk costs. There is no existing infrastructure, as I just mentioned, and so they have a less divided public opinion as compared to developed countries. As such, the developing countries, are in a unique position to start with a clean sheet, to leapfrog, innovative technologies, rapidly adopt new solutions, and maximize healthcare outcomes at the lowest possible cost with optimal use of resources and mindfulness of white elephant risks. Despite in-country challenges, the Global Fund attempts to attain value-based healthcare in countries where it operates. I would like to highlight key challenges and share the Global Fund's positive examples of overcoming these. When we look into challenging operating environments, countries that experience disease outbreaks, natural disasters, armed conflicts, or weak governments, access to health is poor and inequitable. Marginalized and vulnerable groups are even more likely to have very limited access to care. One needs practical solutions and tailored approach to each country context to overcome legal barriers to healthcare and fight discrimination. In light of ongoing refugee crisis, the Global Fund is supporting the provision of essential TB treatment and prevention and diagnosis services to Syrian refugees in Lebanon and Jordan, delivered in cooperation with local and international partners. As we have International Day of the Girls today, I'm of course mentioning access to health for adolescent girls and women, which vary very much in the different countries, so as reaching them with services that include education and social protection. In countries with a high burden of HIV among adolescent and girls and young women, the Global Fund supports the program to keep girls and young women in school because this is an effective prevention strategy against HIV and produces positive health outcomes. One of the building blocks that define value-based healthcare model are holistic interventions. In that respect, delivering a comprehensive and integrated patient-centered approach is vital, yet remains a challenging endeavor. And a health system that puts a patient in the center and not the system is essential for improvement of health outcomes, enhancement of programmatic effectiveness, and achievement of cost efficiency. Value-based healthcare builds on the outcome produced and impact achieved, and the measurement of those relies on the accurate and systematically collected health outcomes data. We heard about that, how important that is. The Global Fund supports countries in strengthening data systems for health, data analysis, and use. In some countries, it is a collection of community-level data. In other countries, data management is done through a network of mobile phones at community-level clinics. In other cases, data management translates into more sophisticated laboratory analysis data. The Global Fund-supported programs often finance the integration of multiple data collection systems into one national health management information system like the one in Ethiopia. Under the overarching concept of leapfrogging and by adhering to innovation as its core value, the Global Fund strives to capture and catalyze cutting-edge technology innovations from across all sectors to drive greater impact, achieve value for money, and influence a behavior change. I wish to present a few examples of what we believe leads to a more efficient, effective, and impactful system. In Kenya, for instance, the Global Fund worked with Pharma Access Foundation and Vodacom to implement a mobile health wallet called M-TIBA. It is an innovative platform that allows payment for health services collect age and gender disaggregated data and test results, and generate a powerful potential for use of data. Started in Tanzania, the project Last Mile partnership leverages Coca-Cola logistics, supply chain, distribution and marketing expertise to support local governments in their efforts to reach the most remote communities with critical medical supplies. And lastly, for early detection of diseases, the Global Fund supports GeneXpert technology that detects TB drug-resistant patterns in less than 2 hours. The Global Fund also advocates for a shorter multi-drug-resistant tuberculosis drug regimes to improve treatment, adherence and outcomes. Ultimately, leapfrogging should target the countries where in-country setting is able to facilitate implementation of technological innovation so that the achieved gains can be sustained in the long term. Hence, a political stability, a conflict and corruption-free environment is crucial for that. Thank you for your attention.
Good morning, ladies and gentlemen. Digitalization is for sure, and I think we are all convinced of that, is for sure helping value-based healthcare. Increasingly, we as citizens and as patients want to be in the driver's seat when it comes to health, disease and wellness. We want to live healthy lives, and we want to be helped by digital solutions to do that. When we are belonging to a risk group, we want to take the appropriate measures to prevent us becoming ill. And when we get ill, we want a first-time right diagnosis, fast and speedy, and from the first time right. And then we want a treatment that is effective and efficient. And finally, we want to get out of the hospital as soon as possible to care for ourselves, together with our neighbors or our parents or our children, and we want to take care of ourselves in our own homes, helped by home monitoring and coaching solutions. Health technology and digitalization is helping us do that by connecting us as patients with our care providers, by connecting all the data that are our data, that are together with, that are defining our healthcare system and our healthcare situation at that point in time, and also by connecting all the healthcare providers in our environment. Now we have to take a sidestep here. The appetite for digitalization, the appetite for new ways of delivering healthcare is not the same in all the countries on this planet. And Philips commissioned a study last year, or in the beginning of this year. The results were published at the beginning of this year, and the study is called the Future Healthcare Index, the Future Health Index. And these are, we interviewed almost 30,000 people, 2,000 healthcare providers, 27,000 citizens, and we did deep interviews with 300 people from health insurance companies, governments, etc. And these are three main conclusions of this study. We have seen that in all the countries, although the appetite for digitalization might differ, data is proliferating everywhere. But data sharing among healthcare providers and between patients and healthcare providers is still a challenge. Second, there is a different perception of how data can help you live a healthy life between patients and their healthcare providers. Patients think of themselves to be better able to manage their own health than their healthcare providers, their doctors do. And finally, there is in almost all the countries that we studied, there are issues on data security, on privacy, on all kinds of government regulations that prohibit digitalization to its full strength. Now in Philips we try to put digitalization at work. We have become increasingly a smart device, software and services company. And we try to leverage this digitalization possibility and digitalization solutions both for the provider as well as for the patient. We help the pathologist coming to a right diagnosis faster by digital pathology and artificial intelligence helping him analyze the slides of the tissue. By integrating digital imaging with our imaging machines, CT scans and MRI, we can provide the doctors with much more accurate images of, for example, the brain or other organs in the body. We can help him by overlaying digital solutions over the imaging solutions by doing targeted precision therapy on liver tumors. And we can integrate digitally all kinds of data around patients to provide care providers with a dashboard that they see with one view at the screen. They see all the vital signs of their patients all at once. And we come close to the home. We are in the last yard to the patient. We help patients and citizens and people living healthy lives by providing them with wearable solutions, with scales, with watches, with blood pressure monitoring, with our lifelines, which is a fall detection device, with automatic pill dispensers and with solutions at home that combine some of these functionalities. And I'm going to give you two examples in the next two slides, one from the developed world and one from the emerging markets. This is a large-scale contract we did with Banner Health in Arizona. Together with them, we defined the 5% of their patients with chronic diseases that were responsible for almost 50% of the expenses in their healthcare system. And we provided them with a set of solutions. First of all, they had all kinds of personal devices at home. They had blood pressure measurements, they had weight scales. Next, they had a tablet at home, not only to feed back their own data from the measurements of their devices back to them, but also to connect live with their care provider. Because the third component of the whole system was a 24/7 availability of a doctor or of a nurse that could help them when they got into trouble. The results of this was that the expense in their healthcare system went down with almost 27%, 27 to 32% depending on the location. And the percentage of readmissions or admissions to the hospital of these frail elderly people was reduced by 45%. And they told us after having this solution for 3 years now that they saved more than 100 million in their healthcare system of Banner Health in Phoenix, Arizona and the surroundings. This is an example from the emerging markets. This project is called MOM, Monitoring Mobile Obstetrical Monitoring Solution. First, we did the pilot in Padang in Indonesia to see if we could help women mothers in remote areas deliver a healthy child. Child mortality in Indonesia is still very high. And we provided the care providers in these remote areas with a portable ultrasound solution, which is called Lumify, that can be connected to a tablet, and the data, the images of the ultrasound of the pregnant mother can be streamed to a nearby facility, a hospital, where they can give advice how to manage this pregnancy and feedback this advice to these remote areas. After having been successful in this pilot, together with the government of Indonesia, we rolled out this system in West Sumatra on a large scale. In order to bring all these digital solutions close to the healthcare, into the healthcare, some things need to be arranged, some things need to be done. First of all, we need to create a single digital market. We need to standardize how we deal with data and how data are stored and managed. And we need definitely to have more easy to work with rules and regulations as far as data privacy and data security is concerned. We will never have a system that is 100% safe, but we should be able to convince the public that the technique can work to a very, very large extent towards this almost 100% security and safety. Thank you.
Thank you. So little confidence in me. Thank you very much. So good morning, everybody. I'm Paul Hudson. I'm the CEO of Novartis Pharmaceuticals, and it's a pleasure to be here this morning, and also a pleasure to listen to the panelists so far. I'm struck, actually, by listening that, regrettably, we seem to have the usual suspects as examples: the Martini Clinic, the Karolinska, Banner Health, of course, recently. All worthy examples of what it takes to operate in a values-based healthcare system, but not enough. And over the next few minutes, I'll just try and give you a perspective on the pharmaceutical front as to what we think about value-based healthcare, give you a perspective of Novartis particularly, and then maybe give you some thoughts around why it's difficult, but why we must persist. So Novartis Pharmaceuticals believes entirely in the delivery of value to the healthcare system. We believe, and I think rightly, that it's the only way to continue to demonstrate our value to populations and to those that need medicines, and to play a role in the future of healthcare. Now, we also know that when we get to a value-based healthcare system, we get to an integrated, aligned, incentives-driven healthcare environment, a closed system almost. We need to be in a situation where we're all trying to achieve the same thing. Why? Because we know, and it's well documented, that 20 to 40% of medicines costs are indeed wasted because they're given to the wrong patient, they're suboptimal dosed, they're not monitored, patients don't adhere, and they fall away. We need to operate together, both from a data perspective, from a caregiver perspective, from a prescriber and a payer perspective. But we need to be aligned to do that, or we can't take waste out of the system. Now, let's assume that we are aligned, and let's assume we have sophisticated measurements of what good health outcomes looks like. Let's say we get it right, and let's say our mission is to improve patients' lives or even extend patients' lives. Now, that's a worthy cause, and it's something that the industry particularly and Novartis can focus on. It's something we believe that would reward innovation and that we're prepared to stand or fall by the value of our medicines that we bring to the healthcare marketplace. Now, we try, and we try repeatedly, and we try through technology, and we try to create systems that allow us to measure very sensitive changes in patients' condition. We can look at the sensitive change in weight, for example, in heart failure patients, and try and figure out whether they're going to have an event that costs money, an event that's distressing for the family, and indeed terrible suffering for the patient involved. We provide apps and we provide mobile spirometry so that patients with COPD and respiratory disease can monitor their own disease and can look carefully about whether they're worsening. And often the predictive markers of how this looks are way before the symptoms have changed, way before the crisis event, way before the patient needs to go to the emergency room. This is a moment where we can sort of get ahead of the disease and we can make an intervention. We can connect that data from the app and we can connect it to caregivers, to nurse call lines, to physicians in an emergency setting, and make the intervention at the right time. We believe it's the right thing to do. We also believe that we should stand or fall again by the value of each individual medicine and make a decision on whether we're prepared to underwrite the risk of using that medicine. We have a medicine for heart failure, Entresto, that improves cardiovascular mortality. You're 20% more likely to be alive than dead at the end of 12 months if you take the medicine. That's not always the most interesting measure for some of the healthcare environments we operate in. Sometimes it's more about how often a patient readmits. And in the US, for example, the question, because that's where the quality measure is indeed whether a patient readmits within 30 days. And if they do, then of course the prescribers and the local payer environment will reduce the incentive paid to the prescriber if the patient readmits. In fact, in some emergency rooms in the United States, and you may know this already, but I still find it quite an important thing to consider, some emergency rooms now have interventional cardiologists in them, in the emergency room, with the sole intention of, when a patient admits at day 29 or day 28, of actually making a decision on whether they cannot complete the administration forms to readmit the patient, but control the patient in the ER setting, thus not failing to meet the 30-day readmission target, which means, therefore, that the incentives for the prescribers and payers remains intact. Now, that's not a closed-loop, joined-up system, but we try and break that by saying we will underwrite the cost for that. If a patient readmits on our medicine, why shouldn't we? If we believe in it, if our pivotal studies take us to that place, then we should underwrite that cost. We also have a lot of success around the world in places like Tasmania, for example. Why Tasmania? Because it's a closed-loop healthcare system. Because we know where there are silos, and I think Stefan mentioned it earlier, where there are silos, it's almost impossible to achieve value-based healthcare because everybody's got competing interests. In Tasmania, it's closed-loop. There is a very close connection between primary care and the hospital environment. It gives you a chance to invest in healthcare because, of course, any savings accrued over the long term are reinvested or are accrued to the overall health economy. It needs the closed-loop place to do the work because where we're in silos, we really struggle. Banner Health is a good example, of course, because Banner is incentivized itself as an insurer as well as a caregiver to make sure that it can meet the needs of patients. And if it reduces readmissions, then it gets to offer that to those that are invested in the organization. Now, ultimately, it is a difficult thing to do. And I've been to many of these presentations over the last 5, 7, 8 years. And what I think started off as an industry response to say, well, we will stand by the value of our medicines. Let's enter into an arrangement. What it's become now is a situation where we need to move faster, where we have to accept, if you listen to the panelists so far, that all of the conditions are here for us to do the right thing. And for pharma, indeed, to play its part. We have the technology, we have the measurements, we have the data, we have the motivation. Not everywhere, unfortunately, but we have the motivation. If I have colorectal cancer, I know where I want to be because I know Eric is going to be looking to set the very best standards. It's just not the case everywhere. So regrettably, the number of examples of where we've actually achieved something in value-based healthcare are driven by highly motivated local health economies, highly motivated closed-loop systems where investments in health will be made in the right way and made over the long term, and the data will help us deliver. Too often I'm asked to come and discuss with senior payers, ministers of health, heads of insurance companies, in the US particularly, to come and justify the value of our medicines. And I'm very happy to do it. And I say the same thing every time. If we justify the value of our medicines and their place in healthcare, what will help you move from a proof of concept to a real serious play into population health? Why does it never get beyond proof of concept or motivated local micro-health economy? What will it take to change the health of hundreds of thousands of patients? And when can we step up and do that? So I applaud the efforts in the space, and I think people should perhaps be less suspicious about the industry and its motives. We've reached a point where we have to stand or fall by the value of our medicines, and we enter into all of these relationships in an open-minded and progressive way. What we find on the other side is either a lack of motivation or siloed mentality, or indeed, even worse, regulatory and legal challenges. Where we've tried to help patients achieve better outcomes, we can be accused of over-investing in a local health economy. We can be accused, depending on where you are in the health system, of offering a kickback or services that the health system should provide themselves, even when we're trying to help patients do well, and even when the health system itself is not providing the service. So we're at a very interesting point, and that's why panels and conversations like this are so critical. Everybody must play the part. Everybody must play the part in a transparent and open way. Everybody must have aligned incentives, and everybody must put the patient at the centre of everything we do. Thank you.
So, I'd like then to move into the final 25 minutes of the session and have a debate or a discussion among the speakers. And as I said, starting out, the purpose of today is to take the system perspective. And I think, Paul, you mentioned there are examples that are used, and some maybe used too often, that are pioneers who have moved maybe against all odds in the direction that we're talking about. And the question is, how can we now move to ubiquitous principle of applying focus on patient groups and what we achieve with them? So I'd like to start the panel discussion with that specific question. What do some in the panel see as the main barriers for this development? And I'd like to start with Eric Hans. You and your organization has, together with clinicians, patients, and policymakers in Holland, put this fantastic platform in place to, in a short number of years, establish 23 registries to gather outcomes data. And you saw the results. Fascinating results showing that if you have better quality, you actually have less costs, which is a win-win. That's what everybody would like. But what, Hans-Erik, has been some of the barriers you have seen in the Netherlands, and how has the Netherlands so far overcome them? I'm sure you haven't overcome all of them, but what have been barriers, and what has been the successful strategies to overcome them?
Well, I think if you talk about barriers and sharing data, it's all about ownership, data that are not comparable. We all know the stories of clinicians stating that they have more difficult patients than others. So it's essentially, as I pointed out, to invest in your good definitions. We brought together all the stakeholders in the Netherlands for nationwide regulations about privacy, ownership. I think what's also very important is the transparency. Groups are very reluctant to come into the open with their data. That's why we agreed upon what we call a stepwise transparency. Don't go into the open right at once with all your outcome data, because you need some time to adjust for case mix and coincidence. So we agreed with all the stakeholders in the Netherlands that year one, it's about participation. Year two, year three, it's about structural outcome data. And only if we have enough data for the case mix correction, it's about the outcome data. I think we are a bit lucky because we have a healthcare that's nationwide based and not institution based. So we have very strong stakeholders which we can negotiate with. But I think these are the most important barriers and the way to cope with it.
Maybe, Christina, if I might move to you, because in your role as the president of ICHOM, you were interacting with hundreds of provider organizations around the world who are interested in using the ICHOM standard sets. And yet, not all of them adapt all of the metrics at the same time. What do you see as some of the barriers for those who want to start using the ICHOM standard sets, which are recognized broadly by the community? I mean, they're published in peer-reviewed journals. They're broadly recognized as the right metrics. What do you hear as some of the barriers to implementing the standard sets once they have been developed?
I think that there need to be good examples. I think that we need to build on the areas where there is interest and start with pilots, because I think this is very difficult to implement top-down. So if you start in an organization and really find a medical condition where there is interest in moving in this direction, then I think you turn it into something positive. And then you ignite the organization to move forward and broaden the initiative. That's what we have seen so far in organizations that successfully scale up implementation of more and more conditions. It always started with a small, really interested group of healthcare professionals and also patients. Having said that, we also see, of course, the informatics as a challenge. How do we collect the data and measure the data in order to make it, in order to have the definitions very clear so that you enter it once and can use it across patients with multiple conditions. That's an area where I think there is a lot of development currently going on in order, that's what we also see in our global benchmarking program pilots so far, that in order to make it comparable across countries, we need to have a very well-defined way of how to enter and collect the data. These are the two areas, I believe, to start with.
Great. I'd then like to turn to my left, to Jan and Paul. You both lead businesses which has historically sold products to healthcare, whether it's a medical instrument, radiology equipment, or whether it's a particular pharmaceutical product. You're increasingly in dialogue, I know, both of you, with healthcare systems with an expectation that the end results or the outcome, the buyers want you to be part of the solution. So some would argue that increasingly you are selling a solution rather than a pill or a machine. What are you finding barriers to your engagement with the providers in actually delivering that solution, because it would go beyond the pill or beyond the machine, which means a different relationship than historically. What do you find as some of the key barriers there?
That's a difficult question, but it relates a little bit to the previous one. There are, of course, some barriers within the company, because we have to learn as a company to bring solutions to the market instead of boxes with a machine inside and a service contract. That we will have to solve. The second one, the second important impediment we feel to offer complete solutions is the silos that we have been creating in healthcare over the years. So it is very difficult to come with a solution that crosses all kinds of barriers across the silos within hospitals, and especially across the silos over the whole health care continuum. And it is I would like to refer back to the Future Health Index study that we did. In the 13 countries that we studied, it seems that countries who have already a long legacy in healthcare, who have built their systems over often hundreds of years, are much less eager to go for new digital solutions because there are so much vested interests than countries that start building their system grassroots on now. For example, the United Arab Emirates, they have a much higher appetite to go for digital solutions because they are building hospitals and a healthcare system as we speak. While in Japan or other countries that have already a system in place for a long time, it's much harder.
So I'll just pick up actually on Jan's point there. I mean, for those that have worked in the United States, I think you'll also accept that most of the EMR, or the electronic patient record, was set up for an accounting treatment. It was set up to charge, to bill services. It was not set up to track patient data, and it was certainly not set up to track it of a research study quality to be able to decide what happens next. And somebody told me recently, I think Epic is the #1 system in the United States, and there are over 200 different variations on Epic, which means that it's almost impossible, depending on where you are in the health system, to actually pull the data together to actually find out what really happened next. So the informatics piece is significant. I also understand the growth rate in the informatics expenditure is probably second to none in the healthcare sector. So people are trying and scrabbling, and I agree with Jan again that depends where you are. If you're setting it up the right way. If it's established, you really don't want to let go of those tools because that's what's kept you going. I come back to the point I made from the podium. I still wish we could systematize or industrialize things. When you see Eric's work, you think it makes total sense from a surgical perspective. Why are we not doing that? Why is that not the standard? Why don't we not save money and deliver better outcomes? It's hard for people to want to go and relook at their own practice and make a difference, and it's hard to change what people do, and the incentives aren't always aligned to do it. Like I said, if the incentives were purely aligned, you wouldn't have a cardiologist in the ER just so that you could beat the system on paperwork for readmissions. So some things are amiss somewhere, and I think pharma itself tries to play a part in connecting it. I think, somewhat flippantly, but I get your point, said that we've been selling pills as part of your introduction. I think we've been providing a lot more than that for a long time, and often, surprisingly, we are the mediator in a lot of this conversation to try and get it going. And we go to the table many times to try and do that, and it's a lot of energy required to get people to believe that we're interested and genuinely interested in trying to underwrite risk on major population and health initiatives. And if we deliver, great for patients, great for the system. And if we don't deliver, then we should pay for failure. A final example: I used to work in the non-small cell lung cancer area with the previous company, and I tried to look at a medicine that was for EGFR mutation positive patients, and when they mutated to a different T790M, you don't need to worry about the detail, but when they mutated, they progressed. So I tried to give away the medicine free if a patient progressed, because we'd failed in the treatment objective. And I was told that actually the system was not set up for free medicine. So it was better that we charge for the medicine because the system could handle it. And I'm like, it's jaw-dropping, the inconsistencies. And so the bottom line is we have so much to do. At the moment, it relies on motivated individuals, and it needs to be much bigger than that.
So maybe I'd like to turn to you, to Norbert, because as was stated here, the longer you've had a healthcare system, the harder it is to be innovative and think differently. And of course, the nations that you work with in the Global Fund are nations who, unfortunately do not have healthcare systems. But when you described that you are using some of these modern tools in some of the nations, the mobile phones, the collaboration you described with Vodafone, the delivery systems aligned with Coca-Cola, are you finding that the uptake, that the impact of measuring outcomes in the field, where there's only a hut, there's not a hospital, not even a primary care unit, are you finding that the measurement of outcomes is influencing behavior of the clinicians or the care staff in the field?
I think it's twofold, the answer. One is IT, it's technique, it's the smartphone, and the other one is trust. And it's utmost important that in the field, patients, potential patients, people who need help, trust the providers. And as soon as you got that, you achieve that, then it works. A problem I have, or a problem we have when we are talking about data, is, from my point of view, is sort of data tsunami. We have data from everywhere. We have systems, we have competitions within the systems. So what we have to do, or should try to do, bring them together, standardize them, forget about competition, because we could have much more success if we would work better together, or the collaboration, less overlap than we are doing it at the moment. We were talking about reducing of costs. We set up a pooled procurement mechanism, as we call it, for drugs and healthcare commodities. And within several years, we reduced the costs by 200 million. So this is something for the countries we are working in, that people can pay, can afford the treatment. And as soon as they can't afford it, they don't adhere to the treatment. And as soon as they don't adhere to the treatment, and the treatment is interrupted, then you come to resistances. So the last point I would like to mention is falsified and fake drugs. I think Novartis knows what I'm talking about. So we have, all of us, we have to address that and to fight that. It's an enormous amount of money. So what the numbers I heard in sub-Saharan Africa per year, 400 million, just because of that. So there's quite a possibility to reduce treatment costs and adherence and prevent drug resistance. And we know as soon as we have drug resistance, it's a multifold drug costs, not only the tragedy for the people in need, but an economic disaster.
To tie back to what you said, the cost efficiency you reach when you have a logically organized model. I think one of the striking slides we saw this morning is the slide that Hans-Erik showed with the outcome and the cost. So the fact that there are centers who have bad outcomes, they also spend more on the patients, and vice versa. Now, I'd like to just open up to the panel. I think that is an extraordinarily important slide. What it illustrates to me is if you focus on outcomes and measure it and make it transparent, people will do the right things. You actually will save money in the system. But we've had the opposite for many years. We've focused on the cost of healthcare, and as a result, we haven't improved outcome because all we've tried to do is to run something more efficiently, but not necessarily do the right thing. So I'd like to open up to the panel for other examples that you've seen. Is this a Dutch-specific example? Is this the Dutch system we're seeing? Or are you seeing a similar pattern elsewhere in your practice where you operate?
I think it's definitely not solely a Dutch phenomenon. I have seen data that were presented to us by Abklink, who was our former Minister of Health in the Netherlands, and he is now working for a major health insurance company. And he has studied this in depth on a global scale. And he sees this variance, this practice variance, all over the world. And it will bring costs with it. And second, we are, together with Karolinska Institute, that we are organizing a summit every year. We had this year for the first time. And we had a speaker there from Mountain Health, or Intermountain in Utah. And he was able, in his $8 billion enterprise, in 1 year, to bring down the costs of care just by removing waste by 600 million. Just by removing this kind of waste out of the system, not being tolerant anymore for underperformance. And so it's not a Dutch phenomenon only.
I completely agree on that, and I think we see more and more coming in the direction of this. And there are examples. Mention a few, the Blue Cross Blue Shield Michigan work, where when they started focusing, bringing the payers and the providers together with the university, deciding on outcomes, focusing, they saw a lot of savings and better outcomes. I think what I would like to bring into this discussion now is that I also believe we have come to a point where it's very important for decision makers to really now start to incentivize this work. Because building from bottom up, as we discussed, it's where we need to start. But we are now at a level of that much happening that we also need to see the incentives going in this direction. I think there are examples of this, like the auto choice bundle payment in Stockholm, where you focus on really having value-based payment models in place. There are others like that. And I think this is where we will see the next step up towards unlocking the full potential of value-based healthcare. Because if you focus on also incentivizing, you will, of course, continue then to drive innovation and always look for the treatments that give best outcome for patients. And that's a way of also bringing the life science work and the life science industry into the healthcare and the clinical care, and not have these silos as we have today. So I think it's now time for some more of policy engagement.
So Stefan, just 2 quick points, unrelated points I hasten to add. One is, if you believe in outcomes, which we do, then you have to accept that not all outcomes are positive in the first 12 months. And I think we do get into a difficult conversation where motivated payers will tell you that they're interested in outcomes as long as it returns a positive ROI in the first 12 months. And that's a budget challenge, a current fiscal year challenge, and health is a longer term commitment than that. And I think that's both sides. If the industry wants to get involved, if Novartis wants to get involved, we have to be committed for the long term in terms of outcomes. Its infection perhaps is different to cardiovascular mortality, and you have to adapt depending on what you think the outcomes is. And a small but unrelated point, we have a lot of challenges with the regulators where we're asked to do big post-approval follow-ups in outcomes over long years in multiple thousands of patients. And I think at the last count, post-regulatory follow-up commitments in type 2 diabetes in an oral medication was over $1 billion worth of additional research, all medicines researching the same thing, the exact same outcome, because they're all individually a post-approval commitment. And you sat there thinking, well, couldn't that $1 billion have been spent much better on much deeper work into unmet need, orphan, ultra-orphan drug situations? And we've got a lot of work to do on the actual system to try and get it right, which is why these conversations are important.
Just two things related to outcome. When we contract our grants for the different countries, so the country or the principal recipient who manages the grants get more money when the outcome is 100%, and get less money or gets an incentive when they reached a certain level of outcome. This is one. And we are trying to implement social impact bonds and try to finance gaps in financing treatment in countries by social impact bonds. So having the private sector on board, and it seems to help quite a lot. I would like to leave you with one question. When we are looking for outcome and just focusing on outcome, how do you solve the ethical problem, prevention on one hand and treatment on the other hand? So when you don't have enough money, do you invest it in treatment? Do you invest it in prevention? And how do you get the balance? I don't have an answer so far.
Thank you very much. I'd like to thank the panel, but before we leave, maybe just a couple of words of wrap-up. I think that what I think you've seen is a strong case for change. There are huge opportunities to get more health for the money spent, but what we need to do is to look more at what we achieve for the patients, put the patients in the center, measure the results, and if we do, we get a more efficient healthcare system. That's turning the current paradigm on its head. And although I think all of you have described barriers that are there, barriers of tradition, barriers of resources, etc., the foundation of it is logical. The foundation is what patients want, and it is what clinicians really want as well. And therefore, I think my sense is, in spite of much of a discussion around barriers, my sense is that this panel is optimistic about this development, and I think all are committed that this is the way we have to go. So I hope we will mobilize all of you to be engaged as well and drive for value-based healthcare systems. Thank you very much.